Dr. Roxanna Irani is a UCSF, I'm gonna sneeze. Okay, I promise it's not COVID. Okay. Is a UCSF physician, a member of the UCSF Collaborative Task Force on School Reopening. She's a Half Moon Bay local and fellow CUSD parent, and she loves to relax by longboarding.
Thank you, Kendra. And thank you so much for inviting me to talk. Letitia and Dr. McFedrich and Jose Contreras asked me to speak today to be able to share with educators in the CUSD home base some new and relevant findings that are going to affect next school year. And so all of this presentation comes from the vetting of what we've rebranded as the UCSF CARES Task Force, so the collaborative group to advise on the reopening of education safety. And there are a number of us, about 45 of doctors from UCSF that comprise of this task force, some of which are teachers and many are pediatricians. I represent women's health. And there's so many other adult services in there as well. So we, and this is just a list of the few who have contributed to these slides in particular. Let me advance. A couple of disclosures. As Kendra mentioned, I do have young kids. They go to school in this system, but I'm not presenting today as a parent at all. I'm presenting as a medical doctor and as a scientist. My background as well, so I have a medical degree, but I also have a PhD in biochemistry, so I like to hope that I can understand both sides, both languages of both science and medicine. I don't know everything, no one does, and I'm not paid to be here. This presentation is put together by this group. It's based on our medical and scientific interpretation, and it is to date, what we know, and we also know that it's rapidly evolving. So what I can share today might not be true tomorrow based on new data, and we have to mold and adapt to that. So what I hope to share with you is how we can interpret the data that we do have around the health risk and implication for children in the time of COVID, especially with regards to transmission, and then share the scientific and knowledge information to schools and school boards and educators like yourself around recognizing and mitigating the risks for children and their community members like yourselves. This is not meant to be a set of answers or how it's supposed to be. It's just a presentation of data. And first, I should just say thank you, because whether you think you're essential workers, I certainly do. You are absolutely invaluable to our society and our children. And what we do together right now in the middle of this pandemic is so vital and really impacts their future. And so I just want to say thank you for everything that you're doing. And I know this process isn't easy for you guys either. So pre-COVID, I think we can all agree that we thought that children benefited from a physical attendance at school. And we know that even now that we're in the midst of COVID, there are many different societies which have stated that that's still true. And so there's been a lot of focus about getting kids back into school. But we can't just rush and say that we need kids back in school. We can only do that if we do it in a safe manner, right? And so when we talk about, so in the last slide, especially Dr. Scott Morrow, who is our San Mateo Health County officer, he stated with a very strong sentiment that he wanted to see kids back in school, but then he talks a lot about balance. And we're going to talk about that a fair bit. That'll be a running theme throughout today's presentation. And when we do, I want to stay on the left side of this screen, where when we're talking about where we're getting our data from, when we talk about the policies that we put in place and the sense of security that those policies give us, let's stay on the left. So when we look at data, let's get it from peer-reviewed sources that we trust and not speculative editorials that are not peer-reviewed in the scientific and medical community. And when we think about policy, let's think about policy that will give us the biggest yield with the least amount of effort. And if we are putting policies in place, that if they are in place and they give us an answer, that we have a true sense of security with the answer that we're getting. And I'm going to use temperature checks as an example of this later on in the presentation. But let's just remember to stay in evidence-based, high yield, and truth. And before we kind of go any further, I think it's really important to kind of just call out the elephant in the room. And we have to acknowledge the anxiety and the fear of what we do know, as well as what we don't know. So we do know that the COVID-19 pandemic has absolutely caused economic devastation and financial instability across all communities and all levels of socioeconomic class. And we know that despite the actual illness burden being limited in children, we know that families with young children and school-aged children bear a large brunt of that economic devastation, and that's mediated in part by school closures. And there's education loss, and we know that that loss of education is seen, that's spread, and the disparity has become even further in children of lower socioeconomic class. And there's loss of jobs, or children who are left more under and unsupervised because families have to work outside of the home. And this bullet point says likely increased child abuse and domestic and intimate partner violence, but actually we know that that's true now. And sadly, we also know that even in middle school age children and above, the rates of suicide over the last 2 months have increased. And that is something that this task force is taking very seriously. And with all of these things taken together, there is just an increased amount of anxiety, depression, and guilt in our society, and especially for those caring for children. And all of these things are absolutely intensified by our own personal fears and the fears of the health of our young family members or our old family members, and not just ourselves. So, what do we know? We know that children can get COVID-19. We know that younger children appear to get less sick than adults, and that they have less risk of adults of getting this condition, having severe disease, and also transmitting it. We're going to go through the data that exemplifies all of that. We know that in a school setting that staff and teachers are more likely to transmit to each other because we know transmission from adult to adult is higher than child to child. And the one thing we don't know is a lot of data about middle schoolers. We have good data about our young kids and our older kids, but the middle schoolers, like all middle children, get a little left behind. And we have to also recognize that less risk does not mean no risk. And so the goals should be risk mitigation, meaning how are we going to decrease and protect our staff, our children, and our families by keeping COVID out of school while still providing quality education. And so we know the essential domains, those 4 pillars, which you guys all know really well, and we're going to talk about them in a little bit of detail. So the question is should we reopen schools? And if we do, how can we do that safely? We know that it's a part of the economic recovery process, but mostly it's about the well-being of our children and their education and their futures. We know that there's a lot of fear in the pandemic that children may be the super spreaders or the viral vectors, because they are for many different types of viruses, including the common flu. But we also know that that's not the case in COVID, and I'm going to present that data. And most, from what I've heard and what has been shared with me, that so many teachers are really concerned about their own chronic illnesses or bringing it home. So let's learn about some basics. Some COVID-19 basics, some transmission, how it gets spread, and in the adult versus pediatric populations, what kind of PPE or personal protective equipment you need to protect yourselves, and then what we can do about symptom screening. And again, this is just a summary, and I'm highlighting the key articles that will kind of inform us to give us these best practices. So I've been saying the word COVID-19, but the actual virus is called SARS-CoV-2, but that's more of a mouthful, and colloquially everybody calls it COVID-19. So this virus, SARS-CoV-2, is what causes COVID-19. but I'm going to be using COVID-19 kind of interchangeably for the actual viral name. So how does this virus spread? It primarily spreads by droplets. And what are droplets? So if you were to put your hand in front of your mouth right now, so if I'm putting my hand in front of my mouth, I can feel air, but I can also feel a certain amount of moisture. So that moisture are aerosolized particles and droplets. And so those come out of your mouth, out of your nose when you're breathing and talking, and those float through the air. And droplets are heavy particles. Aerosolized particles are much smaller and they linger in the air versus droplets that fall. So in general, those heavy droplets from an adult fall by about 6 feet. So that's when we talk about this 6-foot rule, that's where that comes from. Now, I'll say the majority of droplets drop actually at about 3 feet. And so if I was just sitting talking softly, not projecting, those are more likely to fall closer to me than farther away. Now, if I was doing something really exertional, like playing a sport or singing, those particles, those droplet particles, have been known to go 17 to 20 feet. And so when we think about distancing, we have to actually think also about the activity with which what we're doing and how far those droplets are going to spread. The key to stopping these droplets are masking, as illustrated on the right. So whether a person is infected or not, if you are wearing a mask, you're decreasing your risk. And ideally, you want to be a masked to masked adult to decrease the amount of risk of transmission. Again, it doesn't make it zero, but it increases your safety. And one of the things that's important, it's not just about the droplets moving. They have to actually get into things called mucous membranes. So that's the layer of tissue that's in your nose, coats your respiratory tract, in your lungs, and actually on your eyes. And that's how the virus gets in, mostly mouth and nose. So it's not just that these droplets are around and on a surface. You can't contract COVID by touching the computer. You contract the COVID by touching a computer and then touching your nose and your mouth, touching those mucous membranes. So it has to have that secondary contact. And that's why the hand washing part of this is so key. And when we think about close contacts versus high risk contacts, a close contact is somebody that's been within 6 feet of you for an extended period of time. A high risk contact, as defined by the CDC, is when you are within 6 feet of someone for more than 15 minutes without appropriate PPE. And so that's a little bit different than just a close contact versus a high risk contact, right? So what do we know about COVID-19 in California? We do know that there has been an increase in cases, and this was the data I just pulled yesterday night to update this slide, because we all like to be as relevant as we can. We know that we've seen an uptick in cases. That's not surprising. I think that's going to continue. We have more testing, more availability, and we're not just testing our high-risk patients anymore. We're testing asymptomatic people as well. And so we're going to have increased cases, and I don't think that's going to slow anytime soon. There is a little bit of good news in California in that the death rate has stayed relatively flat, and actually we're getting a little bit better at treating it because our ICU cases have also stayed relatively flat. I didn't show that here. Another piece of good news is that the Bay Area has done a remarkably good job. Our community is really doing a lot better with mask compliance and compliance to the ordinances of our local health authorities than the Southern California counties have been. And so that it really speaks to our community's ability to stick to those pillars. And I hope that we're able to continue that. We also know that there's been many institutional outbreaks in prisons, in nursing homes. Luckily, we haven't seen outbreaks in places where children are. We know that San Mateo itself has a positivity rate of about 5% of those people tested. But this is all comers. This is adults, children, men and women. But what about kids on their own? What do we know about COVID with them specifically? So there are some limitations to some of the data that I'm going to present to you. First of all, we've only known about COVID for about 7 months. So we don't have anything truly longitudinal, nothing long-term. So I can't tell you 2 years from now, if you're affected even with a mild or asymptomatic case of COVID, what that's going to do to you 2 years from now. The data is small and it's observational. And when we talk about science, we like to talk about our gold standard, which is randomized controlled trials. Obviously, we can't do that right now in COVID, though there's people that are starting. They are not published yet. And so all the data that we have are relatively small case series, and most of them come from outside of the US, though we're starting to publish a lot more within the US, and I'll point out those cases. And when we talk about the data as well, the local prevalence is so important and plays into how that affects positivity rates. And I'll try and point that out too. So when we talk about what we know about COVID-19 in children in the United States, we know that they are less likely to get it than adults. 2% of all the confirmed cases in the United States have been pediatric. And we also know from US data that children tend to get less sick and certainly die far less. And when I talk about lower rate of hospitalization, the metric that's used is basically out of 100,000. So 0.1 kids out of 100,000 who are positive with COVID will go into the hospital. And in adults, it's about 7.4. So you can see the stark difference even within the United States. And we all get very scared about this Kawasaki's, complication of COVID in children, or this multi-system organ syndrome in children, which is the MISC. And that's thankfully very, very rare. And the last time I checked on 7/7, there were only 186 cases reported in the United States. So while it is a very scary complication of COVID in children, it is very, very uncommon, thankfully. And so when we look at the data in California, we can see that this common theme that children get COVID-19 less often than adults and have less severe disease overall holds true. So in kids less than 17, which make up almost 23% of the population, they account for about 8% of the cases. And when we kind of parse out the very young versus the school age kids, so that 5 to 17, they make up about 6% of the cases. And thankfully, they make up no percent of the deaths in California. And this is not exactly mirrored, right? So when you look at the positive cases by age, many of our teachers fall into this middle category, right? That, young getting out of college to getting close to retirement age make up a large percent of our positive cases. Luckily, they make up a low percentage of total deaths, whereas senior citizens, our grandmas and grandpas, are making up a higher percentage of total deaths by age. So the California experience is very much the same as many of the other countries which have been doing the same kind of social distancing and masking policies that we have here in the Bay Area. Probably one of the best examples of that is actually from Iceland, where even in the beginning of this pandemic, they had an incredible capability to screen and test. And amazingly, they still kept schools open, though they, right from the beginning, employed social distancing and masking. And from that data, remarkably, no children under the age of 10 were actually found positive with COVID. And the older kids, so from 10 to 17, had a very low case rate of about 0.8%. And that's in all comers. In the high risk samples, so the people who had been symptomatic or had recent travel or who had a positive COVID contact, in kids, they still had only about 0.5% of positivity as the adults did. So there's something intrinsically different about children and adults contracting this condition. And so all of these are hyperlinks, and I'm going to share these slides so you can go and do a deep dive as you please. And so, this is just pointing out that Icelandic data. And I just wanted to also point out this. And one thing that's very important, that children generally don't show their symptoms. Only about 20% of them, so 1 in 5 are going to be symptomatic. And if that, they're going to be fairly mild. So that means 4 out of 5 are going to show relatively no symptoms. There's other data. So if children aren't getting it very often, but when they do get it, who are they getting it from? And so what some of this data shows is about who they're getting it from, and mostly it's from adult household contacts, or HHCs. So we have some good data out of Switzerland, and then some conglomerate data, some systematic reviews out of the US, China, and some Asian countries, which both show the same kind of thing, that when you have a household that has a positive, it's not likely that the child is the index person, meaning that they weren't the first person to show symptoms, and the person that was most likely to show symptoms would be the adult in the household. And so that holds true in many different case series. And that kind of points that the adults are likely the primary source of this infection, that are bringing it into the home and then giving it to children. So why? Why would that be the case? So when people, so just taking a step back and doing a little bit of science, how a virus enters a cell is that it has to attach to something called a receptor. So remember when we talked about those mucous membranes, so in our nose, in our lungs, in our mouths, those have a receptor called the ACE2 receptor. And that receptor is key for this virus to attach to and enter into our cells. As adults, we have a lot of ACE2 on our mucous membranes, in our nose, in our mouth, in our lungs. Children don't. If they don't have that receptor, then COVID simply cannot enter. And we have lots of data that the receptors, especially in the nose, is higher in adults than it is in children. And its expression is lowest in our youngest age children, and it gets progressively higher. And unfortunately, that middle school age isn't parsed out as nicely as we'd like it to see, but we suspect that it follows along that same line. And this is just some very basic science data. And this is on the y-axis here is a log count. So this is actually exponential, even though the line doesn't look very steep, it actually is mathematically. And here, this just shows basically the amount of that receptor that's seen in the nose. And that is very little in younger children, but much higher in adults. Now, in our teenagers, it's approaching that of adults, but it's not quite at the level of adults. But this is, and this data has been replicated in many different studies. But the ACE2 data can't just be the only thing to explain it. And so it's so important when you're talking about science to look at all sides and all data. And so we know that there's probably something beyond the ACE2 that may affect some children. And so some of the data which points to other mechanisms comes out of China and Europe from the early days in the pandemic, where they didn't see, if that was entirely true, you would have seen the numbers just kind of go up exponentially. But that wasn't necessarily the case for this Chinese data. And in Europe, if we had seen it being solely represented by the ACE2, then we would see basically a triangle here with kids that are 18 having the most cases and then it tapering down for the young. But these data are a little bit mixed, especially the European data, because it has a lot of children which had pre-existing medical conditions, so high-risk children who would have been more susceptible to getting the condition. So it's a little bit enriched and mixed to understand, but there's probably some other players in a subset of children which COVID-19 can affect. But you're gonna say, okay, fine. Kids get sick in general less often than adults. They certainly don't die as much as adults do. But what about, and they don't give it to each other as much, but what about them giving it to me? They pick their noses, and I have asthma, and I'm immunocompromised, or I live with somebody who's immunocompromised. So we need to learn a little bit about how kids can transmit to adults. So we know that children spread COVID less than adults. And there's definitely variation, and that needs to be acknowledged in these studies. There's a lot of variation in terms of the percent transmission from child to child or child to adult. But the overarching theme is that they spread it less. And we definitely feel as though it has so much to do on the safety measures that are involved in the environment that that child is in. And so Switzerland has a lot of cases which they've studied nicely about the adults being the primary versus children being the index. They, in the Netherlands, like some of the Dutch studies and in some of the Asian studies, they actually reported no transmission from children to adults. And there was an interesting case study out of France where a 9-year-old boy was traveling. He became infected with both the flu and COVID-19. When he came back to France, miraculously, he went to 3 different schools, came in contact with 80 other children, and somehow none of those children got COVID-19, but many got the flu. Kids are definitely super spreaders of the flu, but this virus, COVID-19, thankfully doesn't act in the same way. In Chicago, so some US data, there's was a lot of contact tracing done in some very dense parts of the city, looking at child to child or child to adult transmission, and that was fairly low as compared to adult to child transmission, which accounted for about 3/4 of the cases that they found. And then there's lots of people that have asked me about, well, you know, kids don't always have the good toileting habits, and what do we know about fecal transmission? We don't think that that's a large component of this. This isn't acting like a fecal oral transmission, but there still are definitely a lot of data emerging on that. So again, when we present things, it's very important to present both sides. And so there have been data talking about the viral load in the nasal passages and swabs of children versus adults. And they have shown that in some cohorts, the viral load of COVID-19 is actually similar to that in adults. But that's been reanalyzed and looked at by many other different groups. And there seems to be more of a stepwise increase of viral load by age, kind of mirroring the ACE2 receptor theory, which kind of makes sense scientifically. But more so, even in those cases where you have high viral load in the nasal passages of children, they're still not spreading as much, likely because they have no symptoms. They're not coughing in the same way. They're not sneezing in the same way. So they're not spreading virus in the same way. And so this is just another way of looking at it. I'm a very visual person, so this is good to see that there are there's some data which literally say 0% transmission from kids, and then there's others which kind of approximated at about 20. So I'm probably going to buy that it's about 10%, somewhere in the middle, right? Once we get our larger cohorts. So what does that mean? That means that if you have 10 children, one of which may transmit to an adult, but in 9 of those cases, it's going to have been the adult that gave it to the kid. So, and we know that that differs in other childhood diseases, right? There's definitely variability, but it's still much lower than adults. But now you're going to say, well, what about all these cases in Texas and in France and in Israel? And we've had jumps in Oregon and Florida. And these are all really important case studies to look at, right? So when they went back in France to reopen their schools, they had 70 cases, but they actually reopened their schools with very little social distancing or physical distancing, no masking, and 1.4 million kids entered back into that system. So 70 cases being brought in from the community out of 1.4 million is actually, I think, kind of remarkable, despite the lack of social or physical distancing and masking that was available to them. Same kind of thing with the high school outbreaks in Israel. You know, it was within just a couple of weeks of them reopening. And again, they didn't implement strict masking, especially in that, because that happened in high schools and middle schools in Israel. And so if you don't implement strict masking and physical distancing, you're going to have positive cases when you re-enter. And it also speaks to high schools and middle schools being different than elementary schools, that those children are more likely to transmit than your elementary school kids. And same thing kind of with the daycares in Texas, and I'll go over that data in just a second. The rates in Florida, I mean, I think we've all seen the news. I'm not going to get political, but I think all of these cases really kind of highlight what happens in a community will be reflected in what happens in your schools. So if we're strong in our pillars of physical distancing, masking, cleaning, adhering to all of these things, then hopefully we'll be able to keep COVID out of our schools. Yeah, you guys can look at this, this report in a little bit more detail. But again, it was antibody testing, which we don't really trust that much, but more so what I took from this was that it was more the high schools and the middle schools leading to the closures countrywide. And that it was just kind of striking to me. But we also know that they had limited distancing and masking, especially in that really critical time when they reopened. And so what happened in Texas very recently? We know that the Department of Health and Human Services of Texas put out that 1,300 people tested positive from different child care facilities across the state. There were over 800 child care facilities, most of which were adults. 2/3 were adults, 1/3 were children. They didn't tell us the ages of the children. So they could have been 16-year-olds, they could have been 3-year-olds, we don't know. So we don't know if they were concentrated at certain centers, whether it was at, several centers, or whether that was kind of one person at each center kind of thing. And they didn't really talk about the contact tracing. So whether they came in from the community versus being spread within the child care facility. And I think there's a big distinction. And they also didn't talk about any of the demographics. But we do know that the safety behaviors in Texas over the last several weeks when this was shared with us are, inherently different than those of California. So I hope that we can avoid and learn from some of the cases that are out there. So what do we know? In summary, kids get it, but they get it less often and they get less sick. When they do get it, they're most likely going to get it from an adult which they have been in close contact with. And they don't seem to be the vectors giving it to adults. We definitely know that elementary school children transmit it differently than the high schoolers do. And we don't have middle school specific data, but we can probably extrapolate based on the ACE2 data. And when we think about safety in our schools, we really have to think about the safety of staff and teachers, so the adults in the school, and how we can keep them safe, because we know that they're more likely to transmit to each other. So it's important now, we're gonna take the last little bit to go over some kind of nitty-gritty stuff and some tips about how we can implement safety behaviors and reducing the risks. And you guys all know these pillars: physical distancing and measures, are the PPE that needs to be used, testing and screening, and how we need to clean. And you know that there's so many stakeholders here, and that I hope that the teachers unions and all of your staff unions are advocating for personal protection for you all, and the adequate time and access to resources for e-learning tools, and within the school time to clean and feel safe in your environment. And I always add students as a stakeholder because I think they often get left off of that list. We know that kids are highly resilient, and they adapt to so much, but we also have a lot of data that speak to literacy rates in grade 3 and future potential earning at age 40. So we know their schooling now matters for their life. And so we still, whatever form that takes, we still need to do a good job for them. And so let's talk about these pillars in a little bit more detail. And I know that you guys have seen the documents that have been put out by CUSD, and I think that they were fairly thorough. I think they borrowed a lot of some of these slides. And so I'm happy to see that. I'm happy to answer and expand on any of these. So when we talk about implementation, let's frame these guidelines because the focus needs to be about staff to staff transmission and reducing that. And we need to focus on decreasing droplet transmission. It's not so much contact. So remember when I talked about touching a computer, it's not about, you're not gonna get COVID like this. You're gonna get COVID from touching the computer and then touching your nose and mouth, okay? So it's not so much about cleaning, it's about this interaction. If I put something in between, you're not gonna get it. And we also need to recognize that there is a no zero case scenario. There will be positives in our school. Our goal is to prevent it from coming in and limiting it coming in. And how are we gonna do that? We're gonna do that with symptom screening before they get to the door. San Mateo is still gonna do temperature checks. You're gonna ask families who have traveled outside of the area to self-quarantine. I put it 2 weeks, but that might not be the case for you. You're gonna follow the San Mateo Health County guidelines. You're gonna really encourage and create an environment where families should be felt empowered to uphold the honor system. You want them to keep their kids home if they're feeling ill. And all sick people, and that includes teachers, should not come to school. Don't feel like you have to if you are ill. You should go get a test. And this is just kind of the snapshot if you were gonna memorize one slide. These are based off of the San Francisco Department of Health considerations. And remember how we talked about that 6 foot distancing? You know, some of their guidelines actually say for the younger ages that they can be as close as 4 feet because an adult will go basically 3 to 6 feet, but those little kids, they don't have the power to spit as much. I know, remarkably, but generally they can actually be closer to each other as long as the teachers are 6 feet away. But with San Mateo Health County orders are recommending 6 feet kind of universally. The goal should be for everybody to be masked as much as possible. San Mateo County has actually kind of delineated age and time goals, but the more masking you have, the better. And especially if they are unmasked, that 6 foot distancing becomes that much more important. Arrival and dismissal times are actually gonna be key. And that's actually one of my biggest worries is, you know, and as a Hatch parent, I gotta say, drop off and pick up are some of the best parts of the day because you get to socialize, and that's what's so great about our school community. And we can't do that anymore, guys. We can't be getting out of our cars and chit-chatting and dropping our masks and drinking our coffee. That's what's gonna get us into trouble. And we have to think about how we're gonna stagger these times. Are you gonna do it by cohort or are you gonna do it per family? Because what you wanna do is limit the amount of adults onto your campus so you don't want one family having to come multiple times. You wanna have one drop off per family, well, like the adults in the family, right? Classrooms and eating, you don't want to have those communal spaces. So multi-purpose rooms and cafeterias are a thing of the past. They need to be eating in smaller or ideally outdoor space because nobody's wearing a mask when they're eating. They need to be spaced and you want it well ventilated. Moving through hallways, especially in high school, we're gonna get into a little bit more detail about this, but you have to be thinking about one-way traffic. And I really worry too about staff. You know, the first thing you're gonna wanna do is get into that break room and take off your mask and go, oh, I have had it with this day. And that's your big breath. And you've just now, you know, put your droplets everywhere. And that's where we're gonna have our transmission, guys. And it's gonna be so important to be keeping our masks off or keeping our masks on rather, and physically distancing with staff. Wind instruments are a bad idea for now. Singing is a bad idea for now. And contact sports are also a bad idea right now. How on earth are we going to do physical distancing, especially with the young ones? I know my kids, you know, love their teachers so much, can't possibly not keep their hands on them. This is not going to be an easy thing to do. I don't envy you because you love these kids and they love you. But we know that it is probably one of the most effective tools. Keeping distance apart and masking is the key to this. So decreasing or increasing rather the space between people, using airplane arms for kids, keeping them 6 feet apart. You know, the kids are really good at following rules, especially at that young age. So making it a game, and they'll tattle on each other. You know, they'll be like, Johnny's in my 6 feet, you know, and so, you know, you have to make it a part of the classroom environment now. And so especially when we think about contact tracing, if you've really adhered to a seating chart, so the same kids are always going to sit next to each other and they're sitting 6 feet apart, that contact tracing becomes much easier. If you let the kids kind of go in and go mumbo jumbo and they can sit beside anybody they want any day, that's going to be more of trouble in terms of contact tracing. And we really need to focus about respiratory transmission over contact surfaces. So that physical distancing is more important, and then the stable cohorts than the like the deep cleaning or disinfecting, because that's where you're going to have your transmission. And so the goal should be for those stable, smaller cohorts. So, you know, we've got now, we know that we have to spread our kids out, but how are we going to do that? We're going to have to do it in smaller, stable groups. And there's a difference between a bubble versus a stable cohort. The bubble is a tight group that never mixes. The stable cohort is a group that stays relatively the same. And those stable cohorts allow for minimum spread and exposure, much easier contact tracing, and it makes masking easier. I know you guys are going to spend a lot of your day being like, get your mask up, get your mask up. There's going to be fatigue with that. And that vigilance to safety protocol is going to be exhausting. And so you're going to have to figure out strategies to make it fun for kids and relatively easy for them to do. And when we talk about bubbles and cohorts, 10 to 12 is always the number that's kind of thrown around. That's not a magic number, like medically, epidemiologically. It's easier to contact trace for sure, and it seems like about half of a smaller classroom. And we talked about the staggered drop-offs a little bit already. And one of the things that's important to do, you know, there's so much shared equipment. Really, you want to minimize the amount of shared equipment. And if there is shared equipment, maybe you want to put it away and bring it out 3 days later. If it's not, you always want to wipe it down, obviously, between cohorts. But if you can't get every surface, you know, letting it sit, that virus is going to die, and then bringing it back out. Things like putty and Play-Doh and sand, a lot of art supplies, you can't really wipe down and so are very difficult to use. So I would suggest avoiding them initially, because if you can't wash it, then you can't really use it. And, you know, I say 72 hours in terms of rotating the equipment because that's kind of the accepted longest amount of time that this this virus kind of stays on surfaces. It has certainly been detected for many, many days, but that doesn't mean it is infectious for many days. That's a big distinction, okay? And I think it's going to be important to build in time in the day for additional cleaning and prep. And that doesn't mean the teacher has to do it all. These kids can definitely be wiping down before and after use of their shared equipment. And I really think that you guys need to think of increasing the depth of your bench in terms of classroom management and the need for substitutes. Because if you have contact tracing to trace to a teacher, you're gonna need a replacement teacher. And I think that that's going to be an issue if depending on what the regulation ends up being about returning to school. So we talked a little bit about this, about kind of the stable, smaller cohorts. And I think everybody's in favor of more the stable cohorts versus the bubbles, because the bubble is really kind of unrealistic, about no mixing generally for 3 weeks. And then not allowing, you don't have to have all that physical distancing stuff because they're so tight. That's just unrealistic. We all know that kids intermingle. And so that's why we're still going to employ physical distancing and masking. And the things you have to think about too is that even the stable cohort within the classroom, after school, they're going to get care elsewhere. They're going to go and play with their buddies. So there's going to be mixing between those cohorts, whether it be on campus or off. And then when you're thinking about kind of, I'm not endorsing any kind of style of school, but when you think about the cleaning part of it, if you're going to have a cohort system, you probably want to do like cohort A is on Monday and Tuesday, deep clean on Wednesday, and then B is on Thursday and Friday, because this kind of strategy of A in the morning, B in the afternoon really requires more cleaning, but also cross-contamination. Also in the interchange, in the parking lots, you know, it's just more exchange of adults as well. And so when we think about that, you know, you have to think of all of the mixing that happens with adults and not just the children. So now we have to think about screening, and that has to now become just a part of the culture of school. Universal symptom screening is the first step to that. It's the most basic and easy way to keep COVID out of school. If somebody's symptomatic, they should not come, period. And unfortunately, at this time, universal testing just isn't an option. And that's just availability of testing. Not to say that we don't wish that we could. It's just not an option realistically. You have to comply with your county health orders in terms of timing and criteria for symptomatic students to come back to school or asymptomatic. And remember how we talked about close contact versus high risk contact, and the return to school might be different for both of those. And remember, if a teacher is positive, that might mean that they were in close contact with all of the students, versus if a student is positive, they're only going to have close contact with those who were within 6 feet of them for prolonged periods of time. So if they have a stable seating arrangement, then hopefully that'll minimize the amount of kids that are out. When we talk about symptom screening, that's your entry pass to get in, right? So there's 2 parts of symptom screening: verbal and visual, passive and active. The verbal is simply being asked these questions of exposure to COVID, temperature, chills, some of the other common symptoms. But again, remembering young kids especially, 20% of them are going to show symptoms, but that means 80% are not. So it's important though to do that visual screen as well. If a kid looks sick, they can't come in, you know, if their cheeks are flushed, they're grabbing their bellies, they're shaking, that's probably something that needs to be investigated. And so when we talk about passive versus active test screening, passive is just the asking of questions, and then active would be temperature checking. So again, exposure per the CDC is defined as greater than 15 minutes or less than 6 feet with incomplete personal protective equipment of a COVID positive person, right? So that'll be like a household member who's positive, which you obviously are in close contact with. And when we talk about fevers, so remember in the beginning, we talked about peer-reviewed evidence, being high yield, and having a true sense of security. So when we talk about temperature screens, we know that only 20% of kids will show symptoms, and less than 50% of those will have a fever. So very few percentage of children are actually going to be positive fever because of COVID. They might have a positive fever because of many different things, but it's not necessarily going to be because of COVID. Kids generally have a malaise, and it's mostly GI upset that they present with, as opposed to adults, which have sore throat and fever. And those are presenting symptoms on adults. So the data, excuse me, our data tells us that perhaps temperature isn't the best thing that we need to be checking. And it's a lot of effort to screen everybody. And if a kid has a negative screen, I just worry that we're going to have a false sense of security about that, right? Because just because a kid doesn't have a positive temperature doesn't mean that they don't have COVID. So don't think, oh, well, they didn't have a fever, it can't be COVID. That's actually not true in the pediatric population. And when you're talking about temperature screening, generally people are using the infrareds. The infrareds notoriously read slightly lower, which is why most of us use 100 as the cutoff. 104 is like the classic actual fever temperature, but 100 is the cutoff. And I would never make a clinical decision based on an infrared. So I would, if I was designing it, I would take a positive screen from the infrared and then do a proper temperature check with a better thermometer. And if that came back positive, then you know it's a real fever. And these are just examples. This is from the San Francisco Department of Public Health of the kinds of questions they're asking parents before camps. And then some other tech savvy places, like, you know, I work at UCSF. I have to go through this screening every single day. We have an app. Hopefully there will be, you know, money in the budget to support an app for CUSD so that parents can show it. So it can be a no-touch screen that you can show, a screener can look at it without any exchange of paper or anything like that. I don't know if we're quite there yet, but hopefully we will get there so that there can be an app to do this with. If not, having parents record temperatures at home and checking off things so that you can move the line along will be helpful. And when we talk about PPE, first and foremost, hand hygiene is so important. Everybody needs to be washing their hands or using alcohol-based solutions to sanitize. 20 seconds of hand washing. It does not have to be with hot water. Any form of water and soap is appropriate for 20 seconds or hand sanitizers. In general, the gen ed staff should be using masks all the time, plus or minus face shields. You know, I think it really depends on which kind of students you're working with. Obviously, if you're working with children who have disability or who have problems with verbalizing symptoms or do produce a lot of sputum because of, you know, whatever speech pattern they have, then perhaps you definitely want to be wearing a face shield along with your mask. There's no real role for universal gloves and gowning for kind of lower risk staff. Gloves really don't do anything to protect you because, again, if you're touching that, hopefully you're not touching your face with gloves, but then why are you wearing gloves anyways? Use your hand washing. That's actually been shown to be better, and it models the behavior for the kids, and I think that that is actually a really important piece of this. For the students, the goal should be all the time wearing a mask as much as they can. Obviously, I think that's less important with the younger ones, much more important. There's no reason high schoolers can't be wearing masks all the time. For those younger ones who like have trouble and are always pulling it off their ears, maybe you would consider gaiters. But I think, you know, middle school and up, there is no reason why those kids can't be wearing masks all the time. Asthma is not a reason not to wear a mask. When we talk about full PPE, that means an N95 mask that's been fitted, a face shield, gowns, and gloves. And so those should be available for your nursing staff or janitorial staff, especially using aerosolizing spray, and staffs that are working with SDC children. And you can reuse N95s. We wear surgical masks over top. You know, like I have one of my own that I always wear a surgical mask over top. I don't reuse for if I've been exposed, obviously, to a COVID positive patient, then that is different. But in my general wear, you know, I have one. And so we've kind of gone over all this. One thing I will say is that you should give yourself breaks throughout the day. So do that in outdoor spaces only. Don't do it in the break room like we just talked about. And I think it's so important for teachers to have higher quality masks. And just know, if you're wearing a face shield, you also need a mask. There are definitely, instances where maybe you're teaching a kid how to read or enunciate, and they may need to see your mouth. I think in those situations, if you can be 6 feet away and wearing a shield, again, I think that's acceptable for a short amount of time, and you're kind of one-on-one with the kid and appropriately distanced. So I think like all of this is kind of a range and a spectrum of safety. And I know that, and I think that, those teachers who work in the speech pathology should turn to like a speech pathologist. All of these units are open, like the ear, nose, and throat doctors, the speech pathology groups at universities are doing this right now and have a lot of best practice. So I would urge you to reach out with specific questions. And I wanted to point out a couple of things. So this is what it looks like to wear a proper surgical mask like this with a face shield. So you should be wearing both. If you're using gloves, don't be touching anything else. That's the point of the gloves. If I'm putting a glove on for a surgical procedure, I'm not touching anything. My hands are like this. I do my procedure. I take my gloves off. I throw them away. They don't touch anything else. So there's no point to wearing gloves if you're like opening doors and touching a wall and touching a doorknob, because again, that doesn't stop you from getting COVID. It's touching your face that does. And I want to point this out, and this is very important, guys. These kind of masks with these exhaust valves should not be allowed on your campus. They are not medical, and they're not meant to stop germs. They do not stop COVID. This is an N95 mask that is medical, and it actually has to be fitted. So gentlemen with beards need to shave because that renders an N95 mask unusable, because the N95 masks, believe me, are very uncomfortable to wear for a long time. The straps cannot cross like this. They have to go up and down like this, and it has to seal entirely. It is very difficult to wear this for a long time. It would be very difficult for you to teach an entire day with one of these on, and probably isn't necessary. I don't wear an N95 mask all the time at the hospital, for example, even when I'm treating patients, unless they're COVID patients. But these are environmental masks essentially. So if you were like a painter or around a lot of dust or there were fumes, you want those fumes to stop getting into you, but it doesn't stop your breath from coming out whatsoever. So you're not protecting anybody outside of you. And remember, it has to go over your nose, okay? The mucous membranes are in your nose and in your mouth. So please cover and pinch around the bridge of your nose. I'm gonna kind of blow through this a little bit so we have a lot of time for questions, but I think there's a lot of good tips in here. When we think about eating and drinking, being outside is so important. No sharing of food. I'm sorry guys, you can't have potlucks, absolutely not. Packaged foods might be acceptable to share, but probably not at the beginning. When we talk about the garbage bins in the eating areas, maybe keeping them open so that people don't have to touch all the time, multiple people touching the same thing. Keep them open so that you can just throw out your garbage so there's minimal handling. And so importantly, remember you're not wearing a mask when you're eating, so sitting away from each other is important, and even assigning seats during eating times will be important as well, maybe the most important. And children can certainly learn to clean off their surfaces before and after. Encouraging kids to bring their own water bottles and teaching them to not lick the water fountains will also be important. So doing it a contact-less consumption. So not making contact with the water fountain itself. And if you can, designate water fountains by certain cohorts and ages. But above all else, hand washing before and after, so sanitizing in and out. So facilities management. So when we talk about the fomites, so on services, we know that this virus it's not a major source of transmission by any means. And that we know that this virus actually dies really easily with cleaning, and that is a good thing. So really, you just have to wipe it down with an alcohol-based wipe or soap and water, and that teachers and students can partake in this. So those high touch traffic surfaces, the doorknobs, the light switches, I would wipe off really regularly. And then you want to limit the amount of custodial staffs. There is limited amounts already, I'm sure, for you guys, but then also that's just more adults. So you don't want to have to do, midday cleaning if you don't have to. If you were going to pick things to spend your budget on, which I know is limited, spend it on cleaning supplies, spend it on hand washing stations, soap, surface wipes, paper towels, things that you can do to keep your hands clean and keep your surfaces clean, because that's what's most important. Again, the bathroom thing comes up a lot. We don't think that it's not so much that it's a fecal transmission, it's about the not washing your hands transmission. So maybe you want to do the same kind of thing. Maybe you want, stall A in this bathroom to be Mrs. Benson's classes, and then you want the other one to be, Mrs. Nolan's class. And so you want to keep the cohorts as stable as you can, even in the bathroom. It's probably going to be impossible to upgrade to like touchless everything, but that's, a pipe dream. And we don't have any data to support that the UV emitting lights or, these foggers and that kind of thing is at all best practices in the school setting. And the UV lights could actually cause skin damage and eye damage, especially in younger children. When we're talking about sports activities for kids, small groups outside is the best. Indoor big groups is the worst, right? That just makes sense. And now I'm just gonna there's just a couple more slides left of just some kind of nitty gritty tips. When we're thinking about movement throughout the schools, it's probably better for teachers to rotate than the students because there's so many more of them. You want to reduce the amount of hallway traffic and multiple students passing in different directions. So keeping hallways one way. Those lockers, are such hangout spaces. So reducing those high density spaces is important. That's probably most important in the high school setting. Ventilation is so key, keeping those doors and windows opening. So ventilation meaning exchange of air. Fans in a closed space doesn't help you. You need that old air to move out, new air to come in. That's the exchange, the ventilation. So we are blessed with great weather in California to get creative and use that outdoor space. And maybe we need to invest in some tents to do some teaching outside. No contact sports for now. When you think about basketball, that is an indoor sport with high exertion and close contact. That is maybe the worst we can do. Tennis, a singular outdoor sport is so much better. It's a spaced activity. So if we can shift all PE to outside, it's probably best. If somebody's going to school for flute or trumpet, hopefully we can support them with online activities to do, or it has to be done outside. You really cannot do that indoors right now. Because remember how we talked about those droplets going so much farther with the exertional blowing. Science is a tough one. We're going to have to really think about that curriculum. This one really breaks my heart because, the middle school and high school is really when kids really do that hands-on, interesting stuff, and they generate that love of science. And I really worry that we're going to lose them and lose a generation of scientists, actually. But we really can't share equipment. Microscopes might be the worst because, you're putting your eye right there, you're breathing right on it, you have to touch knobs and be in close proximity. So that's just going to be a no for right now. So hopefully we can think of some neat virtual stuff that's going to help these kids. Using plexiglass as much as we can, especially maybe in those special education rooms where you want to separate from the kid because you have to use a face shield or can't use masking. to be able to help them learn might be an option. And you really want to limit the visitors, mostly the adults on campus. We talked about control points of entry a little bit, but basically, like, you don't want anybody to be able to bypass screening. So especially in those high school kids, you know, you don't want them coming in the back door. They need to go through this screening. So making sure you're funneling everybody through ins and outs, but that's going to create traffic, right? So you have to think about that and how you're going to space it and how you're going to move people through effectively. If that's with an app, it's probably easier than asking people a million questions. So you're going to have to think of a high throughput kind of system. Transportation is a huge issue, right? With the stable cohorts, how are you going to manage the routes with siblings? And you really need to have screening before they get on the bus, not when they get to the school. You've got to partner with the after school programs so that we can, you know, stabilize these cohorts as much as we can. I don't know what that's looking like right now in the current climate. And I think you really need to assign extra PPE supply for children with special healthcare needs and the providers that are caring for them. Those itinerant staff, so those people who are working at multiple schools, really making a concerted effort to work at a particular site, maybe for 1 or 2 days rather than splitting the day. That's a situation where you might have the itinerant worker staff in a room and then the student comes to them because they are more high risk of going and hitting multiple classrooms. And then you want to limit the shared equipment. So limit the equipment that's going with the students and maybe keeping all the equipment per school at that site. The parental involvement, you can't have adults on the campus right now, right? And so how we can reintroduce them, maybe in the younger ages especially, might be something down the line to think about. And then of course, keeping in mind the safety of all staff members, including the custodial and bus drivers. One thing that I would think about too is really developing a COVID response team for each school. So having a core team that really knows the algorithms in and out, and that you know when somebody's going to be asked to be excused and what they need to do to come back. And that might be different for students and staff. And I would really encourage you to run simulations. You know, if in Miss Foster's class, she notices a kid is, you know, throwing up, what is she going to do to be able, who is she going to call? How is she going to handle that kid? And so it's not so fearful the first time it happens, because it's going to happen. So we need to have those protocols, and it's going to make you feel more comfortable when you've done it at least one time. And then if you have like an isolation zone or an area where a kid who you suspect may be symptomatic, where are they going to go? How are they going to get to that space? The PPE that's used there. And then you also need to think about the trauma and possibly the stigma that may go along with having to go to that area. How is that going to affect them? Are kids going to make fun of them? What is the language that you're going to use? And I would encourage you to make sure that that is a space that has excellent ventilation. Maybe you want to have a tent outside. Maybe you want to cordon off the multi-purpose rooms for that because you're not using it as a cafeteria anymore. So, you know, really having some thought around that. And then for contact tracing, making sure that you have algorithms posted in each classroom, each office, and you want to keep track of cell phone numbers and names of people who may have been in contact with an affected person. And then I also urge you to think about the idea of required testing, because there's definitely disparity in the access to care and the access to testing. And there's definitely different communities who are less inclined to enter into a medical system. Perhaps they're undocumented, or they have skepticism about the medical system, and so might elect to not get tested. So I want to end on kind of a good note, that we do have some reassurance, right? So first of all, there's lots of kids in the Bay Area who are in camps right now, and we really haven't had positive cases of kids in the Bay Area, despite the amount of camps that are going on right now. And we have a lot of data from the Y, especially out of New York City, right when this pandemic hit, in the epicenter of the pandemic. There were 40,000 children at over 1,100 sites, and less than 1% of those staff members became positive, and there was no more than one case at site, which meant that at the sites, it wasn't a thing that was being spread around. They came in from the community, they got stopped, they were not allowed back in because they employed physical distancing, masking, and hand hygiene right from the get-go. And we have similar stuff out of the East Coast from Brown, same kind of thing. Less than 1% of staff members and far less than 1% of children were reported positive, and those were an enriched high-risk group of kids from essential workers. So this is all very promising, and we're gonna have a Bay Area data soon. We have a lot of people working on that out of the camps, which were provided for essential workers in March, April, and May. And now the camps that have been happening over the summers. And so that gives us a lot of reassurance that the practices that the adults are having in our community are serving our children well. So taken together, we know that hopefully we can open schools safely if we choose to. And that there's a lot of thought to be done in terms of stratifying the policies between high school, middle, and elementary schools. And I didn't even get into all of the disparity and inequitability access, but that is absolutely something that needs to be considered in this whole process. There's no perfect way to open a school, and you know that there's going to be messiness, and that's why I think too it's so important to run those drills to feel comfortable with the messiness a little bit, and know that you'll get better at all of this over time. So I really thank you for letting me speak. I hope it was informative, and I'm happy to take any questions. I think Kendra is going to moderate that portion.
We have one question asking if you recommend a specific touch-free thermometer, a brand or a model. Is there one you prefer?
I'm not supposed to endorse anything. You know, if you were to Google best hand touch-free thermometer, it would be in the top 3.
Have personal air purification machines, the ones used in homes and not construction, shown to be helpful in increasing ventilation in classrooms where perhaps windows cannot be opened?
You mean as in HVAC?
Not maybe the industrial HVAC, but like home.
Yeah, so you know the thought about fans that's different than ventilation, right? So when we talk about fans and so air purifiers don't kill a virus, first of all, right? But fans in a closed space may stir up the droplets. And so I would just caution about that. We don't have data about it, so I can't speak to any hard data. But I would just caution about using fans in a enclosed space. The best thing to do is ventilate, which means exchange of air, not recirculation of air. Recirculation of air doesn't help. Air purifiers work on kind of a static, most of them anyways, work on a static thing, and that doesn't kill a virus.
Okay. Is there any time that you think it would be appropriate for a teacher may able to be unmasked?
I don't think unmasked is ever really appropriate, hopefully. But using a face shield may be appropriate. And again, it's all about balance, right? So let's say you have to teach a kid how to read and they need to see your mouth. That kid is asymptomatic, that kid is masked. You have a face shield on for a short amount of time, you're 6 feet apart from them, maybe use just the face shield. Again, it's all about risk balance, right? And so that may be something that might be utilized for teachers who feel comfortable.
How about any common disinfectants that have been proven to be effective?
So any of the alcohol wipes and soap and water, that's all you need. This virus actually dies really easy.
when you use any of those. So your simple Clorox wipes, you know, you don't need a super strong bleach. You need soap and water, thankfully. And it doesn't have to be hot water. All right, so there was some, you know, thought about, oh gosh, we have hand washing stations and it has to be like, you know, super hot, so we got to get heaters too. It's like, as long as you've got soap and water and you're doing that for 20 seconds with good technique, that is sufficient.
What about the recent concerns about aerosol spread?
Yeah, so there's a lot of concern over the last couple of days. I will say that, like, from the data that we have, for the most part, it doesn't really support that. It still supports droplet as the main form of transmission. You know, droplets can go far, but like I said, they don't stay in the air. That's the difference, right? Aerosolized particles stay in the air for a lot longer. And so we would see different prevalence probably and different modes of transmission, like patterns of transmission, if that was entirely true. There might be some cases of aerosolization or prolonged droplet, but we don't have anything to say that droplet or that aerosolizing is the main form of transmission. Right now, still in the medical community, we are working under the assumption that droplet is the main form of transmission.
Okay, how about, did any of the information you presented tonight reflect the announcement today that there will be new CDC guidelines soon?
So I didn't have privy to the new CDC guidelines yet, and I expect that they're probably going to reflect some of this. And, you know, I'm not going to speak to any politics today, as difficult as that is, but I hope that funding to schools is improved, not taken back, so that we can do all the things that we need to do, whatever the CDC throws at us, that we'll be able to manage it.
Are COVID symptoms in children and adults exhibited the same, or how do they vary?
No. So like I said, you know, only about 20% of kids will even show symptoms. And then only about 50% of the kids that show symptoms will have fever as the presenting symptom. Whereas in adults, they most often present with like sore throat and fever and kind of a flu-ish kind of feeling. And so it is different in adults versus kids. Kids oftentimes get kind of this like irritable and GI upset before they get their fever. And that's why that temperature check thing, you know, when I talked about balance, why the temperature check is maybe not worth its bang for its buck in a large setting, but maybe it is in a really small setting where it's not a big deal to do.
Would you recommend that teachers and faculty and staff be routinely tested?
You know, I can't say that I recommend it. Would I love it? Sure. Is that possible? Maybe. You know, the one thing, it's also about that false sense of security. So do I care that a teacher was negative a month ago? No. I care what they are right now. They've had hundreds of exposures since that test, right? So what matters is if you're going to test, then you got to test at what cadence? Every week? That's an awful lot of teachers to get tested. And so that's why, I mean, I'll say, even in our healthcare communities, there were some institutions that instituted universal testing and then quickly went away from it because it didn't prove to be better than universal symptom screening.
Now, how do you think that we should balance educating specifically minority children when it's been shown that their communities are disproportionately affected by the virus?
Yeah, I think it's a real challenge. And what I think that we should do is seek out champions within each of those communities who can help educate, help do outreach, and help communicate the importance of all of these pillars to keep in mind in the pediatric context and in the school context. So I think there's different things, providing education to them in the general sense and then providing education in terms of COVID are two different things. And I think that each of them requires different champions to go into the respective communities to be able to embrace them and bring them in a way that they need.
And to know that you're not offering recommendations or endorsing, but what do you feel, in your professional opinion, would need to happen for teachers, for students to return to interscholastic sports?
Sports is really tough, guys. And it also, I think, for high school kids would be really challenging because it's that breathing, and you can't play basketball in an N95 mask, and you can barely go upstairs many times with one of these masks on. So asking them to wear a mask while playing is not really feasible. In cases, I mean, those might be cases where you want to get testing every week, but then that's really kind of, there's inequity in that, right? We shouldn't just test our athletes and not everybody else. So I think if prevalence is really low in a community, then maybe you can consider that, but I think it's going to be a long time.
Okay, we can set up something today. It's just hard because we have to get them.
If you're on, if you're speaking, if you wouldn't mind putting yourself on mute, thanks.
So are physicians or healthcare workers still recommending a 2-week quarantine? And would that be recommended for children who travel as well?
Yeah, so right now, San Francisco Department of Public Health is recommending that people who travel outside of, they say the area, but, and there's debate on what that means exactly. Is Tahoe out of the area, or is outside of California out of the area? But self-quarantining at home for about 2 weeks as a family. And there's different variations about quarantine and return to work, for example, in different institutions. So some institutions say 10 days, some say 14 days, some say 30 days. So it really depends on what the health, and you will go by whatever the health orders are in the area.
And there's a question about anaphylactic allergies. Are children with anaphylactic allergies been shown to be higher risk at contracting or developing complications if they have contracted the virus?
That's an interesting question. I haven't heard any data about that. I don't know if anybody's looked, but I'm sure, I feel like if that was something that has happened, that I feel like that would be all over the news. So I'm glad that we haven't heard anything about that. But I'm sorry, I don't have any data to share on that.
I think those are all the questions that we've had submitted. Let me take one more glance through and see if there's something I've missed. Let me go ahead and read this in its entirety. This just came. There were 70 cases in France after school reopening, after school reopening some of their schools, but there were at very different state with the curve of cases having gone down, whereas the cases in California are still going up. Also, there are asymptomatic people who can transmit to others. So why can't we test teachers and students before they first come to school and regularly afterwards?
So again, I think it would be great to test everybody before going to school. I think that would be fantastic. I would love to come into school knowing everybody in that school is negative, right? Because then, and that's exactly to your point, in Israel and France, they think that they started school positive, right? So if we could eliminate that, fantastic. If we ask that, then we have to ask that of everybody, right? So again, it's about equity. It's about access to testing. And that's not possible for everyone. In an ideal world, yeah, but unfortunately, I don't know that that's possible. And then again, if you continually test people, at what cadence would you do that? In the medical community, we trust a test for 72 to 96 hours, okay? So you're not gonna be able to test all schools and all teachers every 72 to 96 hours. So you don't have the resources, you don't have the money, and it's actually a very uncomfortable test. So it's a nasal swab that goes very deep, and it is uncomfortable, and you do not want to do that every 3 to 4 days.
Surgical masks can be a little too big, especially on our younger students. Have homemade cloth masks proven to be as effective?
Yeah, so I think for those younger kids, the gaiters, again, like the ones that go around the neck that you just pull up, are a great option because the younger kids especially fiddle, and then there's always like this like pinched open part at the side because their faces are so small. So, you know, using the gaiters is great. Again, we know that they don't spew as much virus. Do we have great data about mask versus face shield versus gaiter in a 6-year-old? We don't have that data, but as we extrapolate, we think that, you know, it's appropriate to send kids to school in a gaiter.
What about any data or information for diabetic children?
Yeah, so those kids are considered, you know, the true type 1 diabetics who, you know, are oftentimes sick. They are considered high risk. And, you know, when we talk about high risk conditions for children, we talk about diabetes, we talk about any immunocompromised child, children with cancers, obviously, and then those with congenital heart defects or other kind of structural abnormality. We don't lump in asthmatics to that, but we do consider a diabetic kid a high-risk kid.
Where would a parent with a diabetic child find information or data?
I mean, if you know how to search on PubMed, you know, that's probably your strongest source of truth. If you'd like to email me directly, I'm happy to pull as much as I can for you. Going on the American Association for Pediatrics website, you might be able to get to some links, or even going to the ADA, the American Diabetic Association website, might have some resources for the pediatric population.
Another quick question about face masks or gaiters. Excuse me, it just ran away. Should the cloth gaiter or cloth masks be layered or dual layered? Is one layer enough?
Yeah, ideally, yeah, you do want more. You do want 2 layers. That's the ideal state. But any barrier is better than no barrier. So I wouldn't not wear it because it's 1 layer. So the thicker woven is better than a thin sheer kind of material.
We had a question about, is there some understanding in why some children have very severe cases of the disease?
I mean, so a lot of it has to do with underlying conditions like I talked about. So diabetes, immunocompromise, use of some immunocompromising medications, and then especially congenital heart disease. So those kids, or who have respiratory issue in terms of like kids who already have a trach, for example, those kids do poorly with COVID. There are definitely children that do poorly who are otherwise healthy. And that's why I presented some of that data from China and Europe, because we don't know everything yet. And they didn't really, in those cases, they didn't really tease out any hypothesis of why. But that is definitely something that we're, you know, collectively as a scientific and medical community looking into.
And as our district considers different educational models, would it be your professional recommendation that a high-risk child, high-risk teacher, or a person who has a high-risk family member commit to the 100% remote learning?
You know, I think it has to do with personal risk benefit, right? So It has to do with how vigilant you're going to be with consistent universal masking, with consistent hand washing, and consistent distancing. So what I worry about for the teachers is that they're going to, you know, come into the break room and take off their mask and go, you know, like, and all those droplets go because they need a break from their mask, right? And that's where this is going to be spread. So you're going to have to just be really conscious. And if you feel like you can adhere to all of the pillars, great. But if you can't, then don't. If it's not right for your family, then don't do it. You know, nobody can make that decision for you. Just before we leave here, I want to share this website for those of you who aren't on any of those PTO lists. This has the link to many resources. It has a link to presentation and then some other kind of important information.
I think we're going to go ahead and wrap up. And like we mentioned at the top, if you have any additional questions or need further clarification, please feel free to contact Dr. Irani at her personal email. And that is Roxanna Irani, IRANI @gmail.com. Otherwise, feel free to contact your own PTO. I will go ahead and, I'm sorry, I'm going to sneeze. It's not COVID, I promise. Oh, excuse me. I will go ahead and I will send the link of the recording and the coordinating slides to your PTO so you can contact them if you'd like to take another look or if you know of somebody who was unable to attend. But I want to thank Dr. Irani for speaking with us, sharing the information, and for everybody joining tonight. Thank you for coming.
Thanks, guys.
Thanks,
Thank you.
Roxanne.